Okay, my talk is about the proliferative vitreoretinopathy, and it was first described by Jules Gonin in 1934, and throughout the previous decades, several terms were given to this clinical entity until the Retina Society Committee described the disease as proliferative vitreoretinopathy, proliferative to describe the nature of the disease, and vitreoretinopathy to describe the location of this disease. The most recent definition of PVR is that it is a multifactorial disease with a genetic background playing an important role together with environmental influences which can increase or decrease the risk of the disease. So this disease is basically an inflammatory process, and genetics play a role in the severity and the production of the PVR. PVR occurs in 5 to 10% of patients undergoing primary vitrectomy. And regarding the pathogenesis, rhegmatogenous retinal detachment is followed by breakdown of the blood-ocular barrier or blood-retinal barrier with the release of cytokines. Then, as a result of chemotaxis, there is migration and proliferation of cells, mainly retinal pigment epithelium and glial cells. And as a result of this proliferation, membranes develop in several places, at the back surface of the vitreous, at the area of the vitreous base, on the surface of the retina, and on the undersurface of the retina. So everywhere there is membranes, if you look you will find membranes more than expected, and this is associated with remodeling of the extracellular matrix. And finally, these membranes contract with the formation of traction retinal detachment, so it is really a combination of rhegmatogenous and tractional retinal detachment and creation of fixed retinal folds. The risk factors are really many, and most of them are consistent with the inflammatory nature of the disease. So they may be preoperative, intraoperative, or postoperative. Recently, it was found that following the breakdown of the blood-ocular barrier as a result of retinal detachment, there is migration of microglia and macrophages into the subretinal space and into the vitreous cavity. This is followed by release of inflammatory products, increased chemotactic and mitogenic activity inside the vitreous cavity, and these act on the retinal pigment epithelium, which is the main cells playing part in the production of the PVR. These cells are also influenced and stimulated by growth hormones released by many of the cells, especially the macrophages, and this leads to loss of the contact between the retinal pigment epithelium and the photoreceptors. And as a result, they detach from Bruch's membrane, dedifferentiated, lose their epithelial morphology and polarity, migrate into the vitreous cavity through the retinal break or breaks. And this leads to the so-called epithelial mesenchymal transition of the retinal pigment epithelium. They acquire a mesenchymal phenotypes and enhanced migratory and invasive property and increase the resistance to apoptosis. So when the inflammation reaches a certain level, the PVR is produced. I would like to mention that there are, in addition to the retinal pigment epithelium, there are 3 other cells. They play a major role in the production of PVR. These are the fibroblasts, the macrophages, and Muller cells. Several classifications have been proposed for PVR. The most practical and the most widely used and the simplest is the one proposed by the Retina Society Committee. There are other classifications that pay attention to the location of the proliferation. Others pay attention to the type of the contraction produced. However, we have to know from the clinical and the surgical point of view that the PVR has mainly 2 components: posterior PVR, which is located posterior to the posterior border of the vitreous base, and anterior PVR, which is located anterior to the posterior border of the vitreous base. And I considered that management of the PVR consists of management of posterior PVR, management of anterior PVR, and management of the subretinal proliferation. So for management of posterior PVR, this is a simple case of posterior epiretinal proliferation and contracting the central part of the retina. So the posterior hyaloid was removed. Part of the posterior hyaloid was removed with this dense epiretinal membrane. It was a thick membrane. And when triamcinolone was injected, after that, we found that there are islands of triamcinolone, denoting that there are remnants of posterior cortical vitreous still present. In PVR cases, it is necessary and very, very important to remove the internal limiting membrane, and the behavior of the internal limiting membrane in these cases differ from one case to the other, but usually they are strongly adherent to the underlying retina. This is another case which shows that, this case shows that the epimacular membrane is a part of the posterior hyaloid. It is peeled with the posterior hyaloid, which appear glistening in this video. And finally, with this glistening or this sheen is induced by the posterior hyaloid, and you can see that the epimacular membrane is a part of the posterior hyaloid. This is another case of multiple peripheral retinal breaks, and all the breaks have a rolled edge. And after injecting the brilliant blue, the nanoscraper is used to start the peeling of the ILM. The more area of ILM peeled, the more you safeguard the retina from the proliferation of epimacular, and you can extend the peeling even to the equator. So, and the diamond-dusted instrument is not harmful to the underlying retina, provided you do not apply pressure on the retina, but apply pressure only to the ILM that is peeled. That is, you invert and you start by peeling the ILM. This is another case of old standing retina detachment, and you can see that the vitreous cavity is heavily dusted with pigment clumps. The posterior hyaloid is peeled by applying vacuum from the 23-gauge vitrectomy probe, and the peeling is done until the posterior border of the vitreous base. If you try to peel further anteriorly, you will induce retinal breaks, and again, triamcinolone is injected to detect the presence of islands of vitreous cortex still adherent to the underlying retina, which also should be peeled. So we actually have two scaffolds for proliferation inside the retina, the posterior hyaloid and the internal limiting membrane. And I strongly believe that both should be removed as perfectly and as meticulously as possible. After that, you inject PFCL to stabilize the posterior retina. This is another interesting case of a highly myopic patient. The vitreous cavity is filled with pigmentation, but notice there is a large paravascular break. And this is a really difficult case because you cannot inject PFCL to stabilize the posterior retina except after relieving all the traction over the posterior retina. And in this case, you will notice that there are several layers of membranes that is peeled from the surface of the retina, whether in the macular area or peripherally. And there are also pigments still stuck to the surface of the retina, which can only be removed by the use of a diamond-dusted instrument. Brilliant blue is injected, and we try to peel as much of the membranes. And some of these membranes come with the internal limiting membrane, as proved histologically in many of the studies. But this is continued until you relieve the traction over the posterior pole. But before that, you cannot inject PFCL, otherwise the heavy liquid will pass through the posterior break into the subretinal space. Again, this is a case of an open funnel, and you can see there are no apparent epiretinal membrane. And the only way to remove these immature membranes is to perform peeling of the internal limiting membrane. Again, this is a case of a narrow funnel. Brilliant blue was injected, and by the use of the end gripping forceps, the epiretinal membranes were dissected, and you can see that part of the internal limiting membrane was removed during removal of the membranes. But you should inject, again, brilliant blue to make sure that all the eye lamp over the posterior pole was removed, and this also should be done carefully in order to eliminate the scaffold 4 proliferation. This is a case of a closed funnel. Also, the vitreous is filled with pigmented membranes crossing the vitreous cavity, and by the use of the vacuum to pull on the vitreous, the posterior vitreous, you can open partially the funnel, but you have to look for the plug. And this is a fibrous plug. This is, again, shaving of the vitreous base, and then using bimanual technique in order to remove the posterior haloid that is still attached, of course, posterior haloid and epiretinal membrane, sometimes with blood, and you can use 2 forceps or use the probe and the forceps in order to remove the membranes from the peripheral retina. Again, the posterior haloid is removed, but look at this case. There is the membranes that drag the peripheral retina towards the ora serrata. So membranes were removed manually in these cases, and you should spend some time indenting from outside by yourself or by your assistant, and in order to remove as much of the membranes as possible. And the aim is to save as much of the peripheral retina as possible. I know that this case will end up with retinotomy, but you have to remove as much of the peripheral retina to save much of the posterior retina as possible, and to perform the retinotomy in the far periphery. This is the case where there is pigmentation over the area of the vitreous base, just those preventing the contact of the retina with the pigment epithelium. If they are close to retinal breaks, if they are extensive, napkin ring, of course, should be removed, recurrent detachment and PVR, and pigmented subretinal proliferation, which I believe they are more criminal than the usual. This is how to remove a subretinal membrane through an existing hole. So the 23 gauge forceps is introduced, and on the visualization through the retina, you grasp the subretinal proliferation, and you bring it out through the hole, and then you apply laser to the. This is what we used to do when we have a 20 gauge instrument, that is the hockey stick forceps, where retinotomy is performed, and it is introduced to grasp the subretinal proliferation and brought through the small retinotomy. I do not do this again. I don't recommend it. And the best way is to remove it through a larger retinotomy. This is a case of napkin ring, and you have to remove the napkin ring and not just cutting it. Again, this is a case of pediatric retina detachment with extensive subretinal proliferation after doing a retinotomy, which should be a generous retinotomy, in order not to tear the retina irregularly. The subretinal membrane was grasped. Here, I'm working with 2 forceps, and I think this is the best way for dealing with extensive subretinal proliferation. You can use one for grasping and one for pushing the retina. Still, there are a membranous subretinal proliferation, and you have to remove all the subretinal proliferation because they are very close to the macular area in order to stop the traction over the macular area and provide the patient with long-term anatomical and visual results. So at the end, what should be done in these cases? You have to complete relief of traction, radical vitrectomy, and as Ivanovich said, vitrectomy is done when the vitreous is gone, so you have to be patient, and you have to radical excision of the vitreous base should be in your mind. The use of triamcinolone to look for remnants of the vitreous cortex, which is the first scaffold, peel the posterior highlight to the posterior border of the vitreous base, and then the eye lamp should be removed, which is the second scaffold for proliferation, radical excision of the basal vitreous gel, complete peeling of epiretinal membranes, timed retinotomy. You should resist the temptation to perform a retinotomy until the proper time, and it should be of the proper extent and location. Endolaser to seal all the retinal breaks, and in some cases you may do it for 3-6 degrees, but be careful not to apply to the horizontal meridian, and the use of the proper tamponade. What should be avoided? I still agree with Filippi that about the scleral buckle. I don't believe that an encircling has a value in treating these cases. Posterior during retinotomy should be avoided. The use of PFCL should be done. Iatrogenic tearing of the posterior retina, because this induces proliferation. Bleeding and any blood should be removed from the eye. The eye should be left completely clean. Avoid the use of excessive cryo. The concept of trial of techniques. So don't try to perform pneumatic retinopexy as a trial, and if it failed, I will perform buccal, and if it failed, I will perform primary vitrectomy, because each of these operations will induce more and more PVR. In conclusion, the recent trends in PVR management are better understanding of the pathoanatomy and the pathophysiology, no buccal, introduction of a small gauge instruments because it's associated with less inflammation, wide-angle viewing system, the use of triamcinolone to detect the presence of the cortical vitreous, dye-assisted eye lamp peeling, and the presence of multiple dyes by manual surgery, and I advise you to put a chandelier light in every case, retinotomy and retinectomy with the measures we said, and waiting for a drug to stop the proliferation. I will emphasize, as Dr. Hani said, on our meeting in Luxor, this is the Egyptian Vitreoretinal Society meeting, and several distinguished guest speakers are invited, and I'm sure it will be a magnificent meeting. So you are all invited to attend and contribute. Thank you for your attention.